Hello, viewers. This is Friday's lecture series looking at various issues related to the prosthodontics. So, as part of the full denture Back to the Base series, today we are going to look at whether it's good to have bilateral balanced occlusion. And the lecturer is Professor Park Sang-won from the Jeonnam National University. Thank you coming from all the way to Gwangju. And I believe 3 years ago, you also deliver lectures on the edentulous patients. And maybe we can start by giving the viewers a summary of today's lecture. Yes, thank you first for your invitation. And I'm really glad to see you again, Professor John. Me also. Now, today's lecture will focus on the most challenging part in the full denture, which relates to in the occlusion aspect, whether you really need bilateral balanced occlusion for all cases and what are the issues you might face when you do not have such bilateral balanced occlusion. Well, I believe it's going to be another exciting lecture. Thank you so much again. So Deno is doing this broadcast, and you can leave on this live broadcast questions. So if you leave questions, you might win a Starbucks coupon, and we will also select best questions and we'll give as gift the Starbucks coffee coupon or the Vision toothbrush set. So looking forward to many questions, and we'll start with today's lecture. Well, hello. As introduced, I'm from the Jeonnam National University Department of Prosthodontics, and today I'm going to talk about whether is it good to have bilateral balanced occlusion in terms of full denture occlusion. And my name is Park Sang-won. Now, for the successful complete denture, I believe the most important thing is to have stability in case of function and rest. And besides that, you should also have good mastication functions. So to create good you have to create good occlusion so that patient would have no issues using the denture. So there are 3 occlusal schemes, and here bilateral balanced occlusion is something we teach at school and also in clinical setting. To create balanced bilateral occlusion, a lot of efforts are of course being made, and for the bilateral balanced occlusion, depending on the form of the occlusal plane, you could use anatomic tooth or non-anatomic tooth, or you could also use lingualized occlusion. So whatever the occlusal plane is, we are trying to create bilateral balanced occlusion. So the basic of this bilateral balanced occlusion is first, in the centric situation, you have to create bilateral simultaneous contact. I think in creating occlusion, this is the basic. So this creating bilateral simultaneous contact is the basic. And besides that, when you do eccentric movement, having the bilateral balance, so left and right sides come into contact, as well as the forward and backward side come into contact at the same time, mean the bilateral balanced occlusion. And if you have such occlusion, then the denture becomes more stable in terms of retention and comfort. You will have more favorable results, and stress will also be symmetrically distributed on both sides. And because of this benefits, so we try to create bilateral balanced occlusion. But in the clinical setting, when you masticate food, the bilateral balanced occlusion do not come into play. So while you are chewing, as you can see, you actually chew mostly on one side. So in such case, there is no balancing contact, and on both sides distributing force, such expectation cannot be really realized. And another thing is that unlike the natural teeth, because this is denture, the sensitivity of the occlusion is rather dull. So it's not as sensitive as natural teeth, and natural movement therefore come to not into that effective into play. So for patient, as they use mostly unilaterally chew, so rather than occlusal scheme, in other words, rather than focusing on creating bilateral balanced occlusion, like this in case of unilateral chewing, you have to have stability. So stability in unilateral chewing, in other words, is more important. And occlusion, as much as possible in full denture situation, it should be more lingual side than the ridge crest. And in the working movement of the patient on the upper side, well, on the lower side, the occlusion is more on the lingual side. Hence, this is one of the reasons why you question whether having bilateral balanced occlusion is always good. And as you can see here, full denture patients do have variable ridge conditions. So in such a variable conditions, this means there is also difference in retention and stability and support. So depending on the patient situation, in terms, given the retention and support and stability are different, creating the same bilateral balanced occlusion, is it good? Or rather focusing on centric in terms of occlusal adjustment, would that suffice? So if you focus on centric, then doing clinical remounting and using different articulators might be less in demand. So with those questions, you always have to think thoroughly whether you always need bilateral balanced occlusion. So you need to really discuss this issue. But of course, bilateral balanced occlusion is very good in full denture situation. But again, it's very complex, very hard to achieve. And that's why you have different debates and opinions. So recent articles I'm going to now introduce to you. This is from 2021 from JPD, and here it says that now, as you can see, it includes 10 systematic review articles, which were again reviewed in systematic form. So as you can see, occlusion here, whether it's bilateral balance or lingular occlusion, or is it canine guided occlusion, depending on situation, objective and subjective clinical performance are evaluated. And we also looked at, they also looked at the patient satisfaction level. So as you can see, for here, bilateral balanced occlusion and lingualized occlusion, and for the canine guided occlusion. For all three cases, in terms of objective evaluation, it has good results. And although not here, or because maybe depending on the journal, it might be different, but in case of a monoplane occlusion and group function, it has a rather low assessment result. And in terms of patient satisfaction, also same results, very low satisfaction level. So the conclusion here is, as you can see here, first is that available evidence suggests that occlusal scheme may interfere with the clinical performance and patient satisfaction. So group function or monoplane occlusion would be slightly less satisfactory, hence that conclusion. And for bilateral balance occlusion and canine guidance, again, have the same for both outcomes had satisfactory results, and lingualized occlusion, regardless of the ridge, in all cases had better results. And in case of monoplane occlusion, it has less satisfaction, and group function, it was inconclusive in terms of results. So here again, in 2021, and it's in the leading journal of prosthodontics. And here, for the complete denture occlusion, they looked at evidences to find consensus statements. So evidence-based consensus statement, and as you can see here, so they looked at 34 related papers or journals, and the first question they looked at was whether does bilateral balanced occlusion result in less alveolar bone loss. And the answer on that question was that through analysis, it shows that anatomic occlusion had less bone loss than monoplane occlusion. That was their conclusion. And on the second question, does bilateral balanced occlusion result in higher satisfaction level for patients? There were some that saying they had higher satisfaction level, but there were also literature that also said less satisfactory. And then, in terms of chewing ability, is bilateral balanced occlusion better? Here it says the evidence was weak. And the consensus conclusion of this literature or article was that the first one might be most important. There is strong support that with the average denture, if it functions adequately, regardless, it doesn't really matter what kind of occlusal scheme you have, be it bilateral balance occlusion or canine guided occlusion. There's not much of a difference if it's functioning adequately. And second conclusion is in terms of preference or satisfaction as the chewing ability of patient, there is no strong support for or against bilateral balanced occlusal scheme. But when it comes to non-balanced occlusion, it's had a bit more resorption of alveolar bone that some literature stated that or indicated that. And the last is the author's opinion. And the author's opinion is that for the bilateral balanced occlusal scheme, in case of there's a severe bone resorption, hence there is a weak stability and retention, then the author thinks that such a occlusal scheme would be necessary. And in most recent JPD article coming from 2023, and here they looked at 60 patients, 30 creating with the non-balanced occlusion and 30 with the bilateral balanced occlusion, and they did the evaluation. and it shows that bilateral balanced occlusion is more complex and time-consuming to create, but compared to non-balanced scheme, there's not much significant difference. So these are three literatures that we looked at, and it all seemed to say if it's normally functioning and normal level of bone, for that type of patient, occlusal scheme is not that important. That seems to be the common conclusion. And in discussion of this literature, if I may summarize, the comment made on this articles are the BBO in terms of stability and comfort. It has influence on the stability and comfort of the denture, and has less bone resorption. In other words, there's a bit higher protection, and that BBO in terms of has a better position stability of the denture, so hence has less foot impaction. And lastly, I also agree on this point that creating new denture compared to other occlusions, this is more, it can deliver a more favorable result to patient. In other words, patient find it more comfortable to adapt. So in terms of mastication efficiency and in terms of bone resorption, it's more favorable. In terms of mastication efficiency and mastication time, it reduced them and it reduces lateral forces. You can chew better. So lingual occlusion have such advantages. For the canine guidance occlusion, aesthetically, it's the best. And also it's easier to make. In terms of muscle activity and masticatory efficiency, it's better or it's good. So if it's no excessive bone resorption, you could go for such a scheme. I think these are the comments made. Well, could we maybe ask some questions that we've been given on our site? So I think Dr. Hoffman wrote a very famous occlusion textbook, and he did a one-day course a long time ago in Korea. And Dr. Hoffman said in full denture, canine guided occlusion can be used very effectively. And at that time, it's, as I said, long time ago. So bilateral balance occlusion was the main approach, because it was very conservative at the time. So we were kind of curious about such Dr. Hoffman's comment. So do you have experience for such canine guided approach? Actually, I have not really intentionally created canine guidance approach. I'm with the school, so naturally the general approach is doing the bilateral balanced occlusion. So for the research purpose, I did not really comparison. So I don't really have much experience for the bilateral balanced occlusion. So I also feel for the full denture patients, basically the most important thing is that you have to be able to masticate well, and then occlusal scheme, and you also have to look at the lateral movement. And the occlusal scheme, it's not actually good in terms of chewing. So because you do not have bilateral balance occlusion, it does not mean it cannot function, right? Although some literature says that. What do you think? I also agree to your opinion. I also think in that way. Well, thank you for that answer. Now, as I said, in the Deno website, the viewers have been posting questions. So let's try to answer a few of them. So we have many saying that thank you for good lecture. And ID Pang Pang said, in mastication, if you have food impaction, sometimes it breaks bilateral balance occlusion. So what has the investigation in relationship with the denture stability. So the balanced occlusion in the beginning, in terms of full denture, you need stability for the denture to stay on, right? Yes. Well, I also I'm going to talk about that a bit later on, but once you have food in there, so the bilateral balanced occlusion that you really create only when you try to swallow does it start to function. If the food is a bit big, then you actually try to chew on one side. So if it's not the teeth coming in contact, to chew food, it becomes meaningless. So in that case, unilateral occlusion, in even such case, denture not moving. In other words, staying stable is more important. Yes. So I think I'm also with your opinion. And next says, with the idea, I like balanced occlusion. In terms of denture compatibility, tissue compatibility, and of tissue compatibility and balance arrangement, which plays bigger role? Again, from the focus point of denture stability rather than denture compatibility. So I think the key of the question is, he thinks denture stability is more important. Yes, when I teach my students, I also say that even it's really has good retention, withstanding occlusion with the full denture, there is always shortcoming. So always stability, how to make denture stability for especially mastication, that should be, I believe, the focus. And blue sky is the idea is that when you do try in of the bilateral occlusion limb, bilateral balance occlusion is something not to be checked. Why is it so? So trying of the occlusal limb, you do not see bilateral balance occlusion, do you? So in the occlusal limb, the bilateral balance occlusion, as you know, to make balanced bilateral occlusion, the arrangement, the occlusal plane or compensating curve, or the cost inclination, all should be considered. So in the level of the occlusal limb, probably not there yet. So in arrangement, only that in this step, you have to check those. Thank you for good lectures. Are the next posts and JM2875 to guide bilateral functional occlusion. What are the treatment for the asymmetrical resorption ridge? So I think it's asymmetrical situation, and for the bilateral to guide bilateral balance occlusion, in what are the treatment method for asymmetrical resorption ridge? I think he's looking for a treatment approach. I don't really quite understand the question. So it's asymmetrical. One side is resorbing more than the other side. So there, to create any challenges in creating bilateral balanced occlusion is the question. Well, maybe, but I think in clinical setting, that might be the situation you might meet. But in bilateral balanced occlusion, in creating that, I do not believe that comes into play. Yes, maybe in functional state. Well, one ridge might have more stability than other weaker ridge. Maybe that is the case. Yeah, probably so. Anyway, we will return to the lecture. Thank you for your answers. And again, thank you very much for all your questions, and we look forward to your continuous questions. And I said before, you have a chance, if you post question, to win coffee coupons. Yes, please continue. Thank you very much. Now, maybe this also relates to the questions that we try to answer right now. In terms of occlusal schemes and denture stability, for the bilateral balance occlusion, if there's no food or the food goes through and comes into contact, comes into play, but when you're masticating, in most cases, rather than bilateral balanced occlusion, having the balanced occlusion in case of mastication is more important. So most patients are doing unilateral chewing. That means when you chew on one side, the other side moving and being out of place or becoming unstable should not be the result. So from that perspective, rather than occlusal scheme, the denture stability or the tooth positions, how you set the positions become more important. And for this patient, well, was my patient, so I include that in my lecture. So due to cancer, this patient, about 3/4 of the maxilla had to be removed, but fortunately there is one implant here. So retention for this patient, with one implant, we could gain that. And for other on the ridge area, when we create denture, then this denture, if you create just normal denture, for this patient, it used skin graft, so there is no need of obturate. So if you have a full denture, considering the weight of the denture and other things, there might be no resistance, and implant could break sooner. So we created this small denture, and in the beginning, the patient had difficulty adapting to it, but now he says it's very comfortable, and he had natural teeth on the mandibular side, and of course, it was inevitable, so patient had to adapt. But even with this denture, in the stability in unilateral chewing, considering that, if you consider that, then more or less patient can still chew. So when you create denture, unilaterally, considering that most patients are chewing on unilateral side, the interridge relationship or more lingual occlusion or the neutral zone, such concept always need to be taken into consideration. And especially for lower denture, if you do not have ridge, then if the ridge is in this good condition, no problem. But if it's in this situation, then of course retention and stability would be poor. And in my treatment, what I focus is here. So mouth opening and closing, denture should not be moving. So when you open the mouth but the denture moves, then there could be food impaction. Hence, all this need to be taken into consideration. And in terms of retention and stability, if the denture has good retention stability, then I also agree occlusal scheme is not such an important aspect. So in clinical situation, when I treat patient through remounting on the articulator, trying to force bilateral balance occlusion, sometimes I don't even do that. But still, if there's a severe ridge resorption, hence stability and retention cannot be secured, then for that patient, bilateral balanced occlusion or lingualized occlusion could be the approach. But if it's really a serious situation and with the unilateral chewing, the patient cannot really chew, then as a last resort to the patient, try to intentionally force a patient to chew on both sides at the same time. Of course, we have to make a maximum effort for the retention and stability, even such cases. But for the bilateral chewing, then again, occlusal chewing is not such a sensitive issue. So for successful denture occlusion, this means when patient opens or closes the mouth, the denture should be always in place. And when you do unilateral chewing, the mastication should be done well. And the food, of course, chewing should always be done well. So lastly, this is my last slide. So bilateral balanced occlusion for severely resorbed ridges, I also think is very much necessary. So that will reduce food impaction, and adaptability to new denture would also increase. So when you create new denture, after delivering to mouth, the patient always moves left and right. And if it doesn't really stay in place, the patient complains a lot. So for the first denture patient, if you have some balance, it helps patient adapt to the denture more quickly. And as was also mentioned in other literature, after time it becomes all the same, whatever the occlusion scheme you have. And I also agree to that position. So with that, I would like to conclude my lecture. Thank you very much for your lecture. So Professor Park, we had actually answered some questions already, but we will now answer the remaining questions posted to the Deno website. So there's a lot of questions coming from I like bilateral balanced occlusion. So monoplan, does that mean it's costless? Then in case of mastication, there's a complaint from the patient because of the weaker mastication efficiency. Yes, that is true. The efficiency is lower, so the patient is less satisfied. And later on, they say there's more bone resorption. And also, for patient with a lot of rich resorption, costless area teeth with lower angle should be used. That's what the textbook says. So, you know, because sliding centric, if that happens, you would have a bad result on your hand, right? Yes, I also agree. But for me, if the ridge is bad, I don't really use monoplan. If possible, for those patients, I try to create lingualized occlusion, and the patient also seems to be more or less satisfied. Yes, lingualized occlusion is a good approach. It's not that tricky as bilateral balanced occlusion. And then next question we have, what kind of occlusion is good for the patient with very low ridge? So with the patient that has not much ridge, what should you do? Well, for that type of patient, actually, bilateral balanced occlusion, you don't really use only anatomical occlusion. You also sometimes have to create with non-anatomical occlusion, or also with the lingualized occlusion, the concept of the bilateral balanced occlusion. But I think lingualized occlusion must be best for lower ridge in terms of stability. So, you know, lingual, you know, because you can, the lingual occlusion would be the focus. So my recommendation would be lingual occlusion to eliminate any contact from the buccal side. Then the next question from Light, full denture patient, because severely due to unilateral chewing, complained about the denture being movable on the other side and becoming shaky. So what should you do to gain stability and retention for the unilaterally chewing patient? It's a tricky question. Yes, I think for full denture patient, you tell them to chew on the both side, but in most cases, I don't think nobody really can do that every time. You lean toward the unilateral chewing, and if you only chew on one side, as I said before, the occlusal force on the ridge crest, centralizing it should be the efforts that should be made to gain more stability and retention, in my opinion. I think the best would be implant and overdenture, right? Yes, well, I also feel that these days, suction denture and other things, you do that and you make different efforts. But actually, 2 implants and overdenture actually solves most of the problems. That's what I think. But anyway, inevitably, there are patients that cannot do implants, and that's why you have to really think more. So if you do the basics and fundamentals well, then you can adjust in and respond to most of our cases. Next question: any tips for using the check bite for the bilateral balance occlusion and fine adjustment? Maybe use the horseshoe type of check bite. Well, tip for using check bites, for me, arch type paper check bite, I don't really use that much. Me neither, because it's really dull and it's really uncomfortable to put it on the mouth, and it can move because of your tongue and cheek. So long check bites, 2 at the same time, is what I use. So in the mouth, if you say fine adjustment, it's inevitably happening in the mouth. So I think that might be the more comfortable approach. Next is S191908. Says, patient with flabby tissue, how do you do the upper anterior occlusion? Well, if you have flabby tissue, means the patient suffered from the past issues moving to full denture. And anterior guidance in the textbook, they say give some gap, make it contactless. So I think that should be the approach. If you have the flabby tissue, especially be cautious, have no contact on the anterior upper side. So, and then next one, for the denture stomatitis, what should be the occlusion? So I think patients that have is vulnerable to the denture stomatitis, what should you do? Well, denture stomatitis, was it one-off or repeated situation would determine your treatment, but repetition of stomatitis means rather the occlusal scheme, centric is unstable, and hence you have that on your hand. So if possible, centric needs to be adjusted as much as possible. So centric occlusion is the key, and denture is moving, so it's really hard to the central occlusion. So you have to hold it with your hand, especially on the mandibular side. So if you have the central occlusion well, then repetitive stomatitis, denture stomatitis would go away. But if it's systematic situation, if it's related to other systems, then there's no other option. You have to do implant and bridge. That might be your only option. And then how do you respond to complaint saying that I cannot cut food very well? Well, full denture patients always complain about this, cannot chew kimchi, etc. So, of course, anatomic tooth should be used or lingualized occlusion, we think is the better approach. So if not cut it very well, then contact area, if it's pointed contact, maybe might be the issue. So have wider contact. So surface contact, not the pointed contact. Yes. And then Seung-yu says, if the occlusal dimension is lower or higher than normal, what is side effect? So I think it's about vertical dimension. Well, if it's lower, side effects would be the patient will complain, cannot chew very well because it's less painful, and therefore you have less complaints on your hand. But if it's too high, then you feel rigid on the mouth, muscles feel rigid and rich. They say is painful. So you have to listen to the patient complaints and to determine whether it's about higher or lower VD. If VD is not too high, small difference patients can overcome. But if the socket is too high or other things, yes, you might have problems on your hand. VD, depending on patient situation, it's always changing. So as you said, maybe that should be the way. And if vertical dimension is too high, they say you have the click sound, so and they complain about that too. Yes. And then we have from C. Wolf, what is the important thing for the completion of the balanced occlusion? Can you summarize that? Well, it's really hard, and you cannot really give summary in one sentence. But for me, patient rather remounting articulator, try to finish through the oral adjustment. I think yes, most dentists would do that. But of course, you teach on the school to remount. Yes, in the textbook, that's what you say. But letting the patient wait is not what you do actually in the real world setting. So in the central occlusal side, if there's bilateral balanced occlusion, if you focus on that, yes, centric is always important, because centric, if it's functioned, then patient do not really complain, and patient asking to move around and it's shaky, and you adjust those shaky areas, then not all patient maybe, but if most patient, I think you would not have much problem on hand. So if in the lateral movement, you of course may have to make the necessary adjustment. So I like bilateral balanced occlusion. Says occlusion is really tricky area, one of the most challenging areas, and there are many check devices to check the occlusal forces. So any literature and research on this area? Well, I think T-scan could be one of those devices that is really frequently used, and these days a lot of digital companies do come out with the products, but not many when it comes to dentures. They try to accumulate data and research first on the natural teeth. I think with T-scan, denture patient checking the occlusal force, they are attempting or trying to do that. So maybe Professor Bach, since you are in the dental school academia area, maybe you could also research this about this. Well, actually with the T-scan you can check the relative occlusal force, but when it comes to absolute values, you cannot identify them. How strong you bite, to which patient, it's really hard to determine that. When I was with school, there was the device where you bite on it, then 30 to 40 kilograms was the norm, but for the denture patient, 5 kilograms. Now, when you bite hard, it goes up to 30 to 40 kilometers, but only denture patient only up to 5 kilometers, so only 1/8 or 1/10 it seems. So that's what was I measured when I was at school. And ID says, thank you for a nice lecture today. And CCDCKH says, if you have a lot of alveolar ridge resorption, you said you need more bilateral balanced occlusion. So any standards for doing the bilateral balanced occlusion in the clinical setting? Well, if you have sensitive, very sensitive patient, and on the lateral side, if you are really sensitive, if you do lateral movement on your mouth, even slight there's uncomfort, then they complain and one demand changes. So inevitably then you have to go with the bilateral balanced occlusion, and that's what I do. So if they think, patient think it's okay, then with just oral adjustment, if you just cut the premature, so then it will be okay. So, and then Blue Sky says, by making lower posterior lingual cusp come into contact with central fossa, make occlusal force act closer to lower ridge. Does this make it more adaptable to changed occlusion resulting from lower alveolar ridge? I think the question itself is not clear. So if with lingualized occlusion in from the upper side, you have more force coming, hence occlusion. I think that is correct, right? Yes, lingualized occlusion is what is mentioned here. Then eliminating on the upper buccal cusp, and only with the lingual cusp on the maxillary side, you create occlusion. So it's easier to accomplish it, and with a lot of adjustments, then just simply this area is a premature and other things, you can do such adjustments. And on the upper lingual cusp is the center of everything. So on the ridge area, on the lingual area, the occlusion can lean toward that area. So I think yes, it can be better than that. And next question is, you talked about overdenture. So my question is long-term prognosis of overdenture. Sometimes you see bone resorption around the fixture due to occlusive force. What do you think about that? Well, actually, if you look at various implant literatures, overdenture and general bridge, if you compare the two, in the overdenture, they say there's a slight difference. But I think in more literature, not severe differences. And in my own experience also, not much of problems that I have countered. But I think opposing teeth is the key. If it's denture to denture, then I've also not experienced much of a bone resorption. But opposing teeth, if it's natural teeth, then of course there could be gum issue. But due to occlusive force, this could be the result. Then in that case, you have to caution the patient, don't chew, too hard things, so that you would have less force. Well, bone resorption and occlusive force, it's about also periodontitis. So if it's overdenture, then it's really hard to clean it and manage. Yes, if you're elderly patient, hands are no longer very agile, and it's food is not automatically cleaned. So maybe that's the key. Yes, oral hygiene needs to be more paid attention to. And then we have a question from the YouTube. In the full denture occlusion adjustment, what is the thickness of the cheek bite? Well, I just use Accufilm. So generally Accufilm is about 20 micron, or I think more or less Systag is about 8 micron. So I think 20 micron in the full denture, I think is very wonderful. So many are thanking you for nice lecture. Says occlusion is hard area, so thank you for the lecture. And then Sungyo says, full denture patient has repetitive stomatitis. So why is that? Well, it's also related to VD. They say if you have lower VD, they say stomatitis persists. But if it doesn't go away, that means it's also related to immune system of the patient. So you have to also consider that. So patient, if it's very compliant patient, or maybe increasing VD might be another approach. So, and also I like bilateral balance occlusion. Says thank you for very detailed answer. And CCDCKH says clinically any full denture patient case that stays in your memory, and what kind of problem was it, and how did you overcome those? Well, so any patient that you remember. Well, full denture patient, well, because I'm at dental school, I have a lot of referral from private clinics. So a lot of patients stay in my mind because there are a lot of tricky cases. Yes, if you're referred from private clinics, yes, it's very tricky cases. But still, there are patients, even if tricky case, very faithfully compliant patient and not so much patient. Any patient that really stayed in your mind? It's rather a recent case, and I did not include in my lecture. One patient, mouth floor was really too high, so I could not take any rich impression. So generally, even if there's bone resorption, mouth floor same height or slightly lower, but this patient mouth floor was about 1 centimeter higher. So it was really hard case. But did it end well? Well, it's still ongoing, and recent patient. So it delivered a temporary denture, and it's not coming back. Seems he's doing okay. There are more questions. It says it's another YouTube question from Gogo. In the digital era, in taking full denture impression, do you take the impression digitally or analog? If you do analog, what kind of impression material after border molding do you use? Yes, we are living in digital age, but digital denture is replacing lab technicians, but I think it's tricky to replace in clinical settings. So you take impression analog, and scanning you do maybe digitally. Yes, that's the current approach. Through intraoral scanning, sometimes we can create temporary denture, but on the maxillary side, intraoral scanner can be used for taking impressions. But when it comes to mandibular side, it's almost difficult. You know, setting border is tricky, and taking border is also hard. On the lower lingual side, on the distal side, it's not possible. So impression taking for full denture is analogly done. Maybe after that you can do digitally. Yes, you can scan digitally. And for impression material, I think silicone seems to be preferred option these days. I used to also use another material like geopaste and others, but these days I also opt for silicone. So that's very much in vogue, right? Yes. And also Pora ID says severe mandibular protrusion or close bite patient. It's not easy to do the arrangement in the with edge bite. How to do that? So I think it means class 3. Well, if the patient is class 3, you have to make it into class 3. Our recent patient was class 3, and we made it edge to edge, but he said it was uncomfortable and wanted to do it class 3. So textbook wise, they say edge to edge should be the approach. But if it's not easy, then I think you just go with class 3. And then JM 2875, so edentless anterior bone resorption resulted in having to make gain circular retention up even under the nose. So I think it's maxillary side. You have to do gain retention and sulcus deepening. Would that be possible? Well, if it's upper side, then on the anterior side, even if there's a resorption, on the posterior side, if you have some, retention still can be gained. What do you think? What's your experience? That was my experience. Well, on the upper posterior side, if you have some anterior, if you have none, it's still okay. But if it's just right under the nose, it must be a serious case. Anyways, and then Red Cherry 1 asks, Class 1 RPD, and if you compare that against full denture, what is better for stability of occlusion? Class 1 RPD will be better, of course. If you can do RPD, you always have to go with RPD in your treatment plan. And another question is, do you use a lot of hybrid denture? What do you mean by hybrid denture? There could be different definitions. I believe few implants and then using fixed bridge. So, but it looks like a denture, and I believe that's what you call hybrid. So Oron 4 or NX1, these types are called hybrid denture. Well, if that's the definition, then if you need lip support, then inevitably you have to go with hybrid, especially if you have a lot of bone resorption. So again, it's case by case. If it's necessary, then you use hybrid denture. So I believe that are all the questions that were posted. Thank you for your answers. And thank you everyone for participating in this lecture through the chat box. So we will now select the best question of this lecture. If you are chosen, then we will give you a dental set. So who do you think was the best question of today? Well, the one that asked most question, but I like bilateral balance occlusion. Yes, I saw that's very much in line with today's lecture title. So I like bilateral balance occlusion. That idea. Congratulations, you've been selected as the best question of today. We'll contact you. And those that have won also coffee coupon, you will receive text message on Monday. Professor Park, thank you for your wonderful lecture. But any closing remarks? Well, today we talked about occlusion, so let me talk about that. Well, full denture occlusion is really tricky area because it's about dealing with movable tissue and trying to fine-tune occlusion. Yes, you have to shoot for moving targets, so it's really tricky. And these days, digital denture is also being researched, and other areas you can all use digitally, but not really when it comes to fully when in the occlusion. So occlusion, it's not, you don't have shortcuts. You have to go back to the basic fundamentals, and the key is you have to create bilateral cementation or centric occlusion. You focus on that, and when you focus on then creating the full denture occlusion, a lot of things can be smoothly overcome. Thank you very much again for being with us today. Thank you very much. So, and also viewers of the prosthodontics on Friday, I hope you enjoyed today's lecture. We looked at the bilateral balanced occlusion for full denture. And if there's any question we failed to answer, we will post answers on our website. So we have a lot of lecture series related to full denture. And we looked at edentulous patient and also occlusion. I hope they've been very much helpful in learning more about dealing with full denture. And of course, you can look at the lectures again on our website. And on the second half of this year, we also will continue with the lectures relate to full denture. And I'll see you back on the 7th of July with new topic related to full denture, and the lecturer will be Professor Lee Chung-Yi. Thank you again for being with us today. Thank you so much.
교수님 수고하셨습니다.
네, 감사합니다.
감사합니다.